So we start with approaches and planning in THA. This is a slide you probably have seen many times before, total hip arthroplasty, the operation of the century, titled in the Lancet 2007. So it's a great operation you perform with excellent functional results and very good long-lasting results. So these are data from the Australian registry with a revision rate after 20 years of about 8 to 9%. But if you have a revision, the outcome is significantly worse. So the complication rate will double, nerve injuries, vascular injuries, mortality, and the re-revision rate for another operation is even 4 times to 5 times higher than with a primary. So that's the main message: get it right the first time. And these are the objectives in modern arthroplasty, what the patients expect and what you should provide them. So they expect to be pain-free, they expect good or even excellent function, a stable joint, long-lasting durability, and this is kind of new in the last 10 years, rapid recovery. So patients expect that they will be on their legs on the same day as the surgery, that they will be discharged within 2 or 3 days, or even on the same day, okay? So this is quite challenging for us to provide this, because not every patient is the same. And this needs good planning, and you have to be aware what you're aiming for. And what we try to restore first, this is very basic from the radiology side, is the center of rotation. This is kind of extreme here with a patient with a high hip dislocation, but you have to aim to put the center of rotation back to the native joint. The other thing we'll try to restore is leg length. As you know, with osteoarthritis and wear of the cartilage, the affected side, maybe the leg length will get shorter, like in this case it's about 3 millimeters, and you can easily lengthen the leg during the surgery. What's kind of difficult is shortening. That's not possible, because then you will end up in an unstable situation. And the third thing you try to restore is the offset. This is important for the abductor function and also for the tension. If you overcorrect it, patient will claim about pain on the trochanteric bursa. And if you undercorrect this, it will be an unstable joint. What also is part of preoperative planning, that you have to address certain risk factors, okay? We are often seeing patients with diabetes, so HbA1c should be below 7.7. You have time when you schedule the surgery that the lung sugar gets down. BMI, malnutrition, big problem, now even in Austria. This is data from the German registry. Here you see BMI over 40, and the revision rate is even 3 times higher than with BMI below 30, okay? So this is also something you have to address. Smoking status, patients shouldn't smoke 6 weeks before surgery and 6 weeks after surgery. Then you can minimize the risk for wound healing disorders and for septic complications. Decolonization, so patients would wash themselves with octanisan or something similar. Dental status and anemia. Preoperative training, when we talk about rapid recovery, patients need some kind of preha, so this makes sense. Patients go to seminars, you provide them with the information about the surgery. Physiotherapists show them how to walk with crutches before they have the surgery. This makes recovery faster. And now there's a trend that all the hospitals provide some apps for their patients where they have a timetable, how to, at which time point they are, where they are at discharge, and so on. And this is proven that this shortens the stay in the hospital, lower pain levels, and better early functional results. Now we go quick to the digital planning. Who of you is planning on the computer his arthroplasties? You? You? Don't be shy. 2? The other ones do it manually? Okay. So what we need is the right X-rays for planning. So you need an AP hip, and this is usually done in 20 degrees of inward rotation to address the anteversion of the femoral neck. Otherwise, you will underestimate the offset, okay? The other thing is the frog leg or lateral view, that you see any abnormalities in the femoral canal for putting in the stem. And the third thing is AP standing, so that you have an impression about the leg length. These are the 3 X-rays. Then we do it with the planning sphere. Then you also should have a look at the door classification. Is this kind of door A, so this champagne flute, or door C, this stovepipe, sorry. And then you have to think about cement fixation. So as a rule of thumb, these 2 are good cementless. This one you should think about cementing. This is the preoperative planning, how we did it in the past with these templates. We put them manually. And this is how we do it now. So we have a computer program. The most common ones are TraumaCut and Medicut. We are using TraumaCut at our department. So you measure the leg length discrepancy. So remember that it's 3 millimeters. And then you have a selection of all or almost all the implants available on the market. You can choose them, standard offset, high offset, different neck versions. Then you put in your cup, always first, close to the teardrop. And then here is the version with the normal offset, and you see offset restoration will be exactly restored, and the leg length 3 millimeters up, so that is what we would like to achieve. And here's an example with the high offset, you would overcorrect the offset, okay? And then what we do, we measure from the minor troch to the line of the osteotomy. As an intraoperative, we don't use fluoroscopy, so that we know where our osteotomy should be, that we can restore the leg length. And this is the result. 3D planning, we're not using this one. This is more if you use a robot. There you also can address the anteversion of the cup and the stem. Just a case example with difficult planning, so high hip dysplasia. There, probably know these 2 classifications, Crow and Hattophylakidis. This is more difficult to spell, but it's the easier classification. So what we would like to achieve, we would like to achieve the restoration of the center of rotation, and it's down here. You can't only put the cup here and then put the stem up there. This won't function, okay? Because the tension of the soft tissue will be too high. So you have to perform a shortening osteotomy. And this is what you can plan. How long should your osteotomy be? You measure the leg length discrepancy, so it's about 4 centimeters, and this is what you do, how long your shortening osteotomy should be. And this is the result, okay? So we are using a modular stem, like this SRAM stem, put the cup in his native, in the native center of rotation, and then we use the bone from the osteotomy and wrap it around like an autograft. Another case, post-traumatic AVN with a consecutive femoral neck fracture. You see the neck, the femoral head here and the fracture. Here the CT. And here it's good to plan from the contralateral side, so that you know how the offset should be and where to put the cup. And in this case, we did it like this, that we left the head inside and just reamed it, so that we have kind of an autograft, and then put this Busch-Schneider cage over it. And this is, now we're heading to another topic, which is kind of getting popular now in the last few years, is the spinopelvian alignment. You've heard about this? You're discussing this at your department? Yeah. Okay. So I start with a case to bring you there. This is a patient with a dysplasia. She was doing fine with her hip for several years, and you also see that she had a spinal fusion, okay? And then all of a sudden she dislocated. And what you also can see on the X-ray, that the spinal fusion was extended to the ilium. Then there were X-rays performed, and what you see here, this angle is the sacral slope. This was increased, and as an increase of the sacral slope, the anteversion of the cup changed, okay? So this decreased, and this made it possible that for posterior dislocation. So dislocations are still a problem. These are data from the Swedish registry here, 94. These in the year 2020, and still 10% of all revisions are for dislocation. So a problem we haven't addressed adequately over the years. Overall, dislocation rates are between 1.5 to 5% redislocation rates. So if a patient once dislocated, 1/3 of them will dislocate again. Most of the dislocations are posterior, and 50% of all patients who had a dislocation will need another surgery revision. Okay, so keep that in mind. What are the risk factors? The patient-related risk factors are neurological disease, like you can imagine Parkinson's disease or dementia, drug abuse, alcoholism, obesity. Patients with AVN have a higher risk for dislocation, and a previous spondylolisthesis. So if a patient had a total hip arthroplasty and then had a spinal fusion, in the first year after surgery, the dislocation rate is 3%. In the second year, it's even 7.5%. You all have been trained with the so-called safe zone from Levenik. Okay, so you put your cup into 15% of anteversion and 40% of inclination, 30 degrees of inclination. But over the years, there have been a couple of studies, like this one from the Mayo Clinic, that have shown the safe zone isn't that safe. Okay, it's too static. So here, this box is the safe zone, and all these patients, these little dots, are patients that dislocated within the safe zone. Okay, so it doesn't prevent dislocating. There are a couple of studies who showed that, okay, all these are the percentages of patients who dislocated within the safe zone, even 92%. But if you have a closer look at these patients who dislocated, you can see that they have spinal risk factors, like a flat back or a posterior tilt of the pelvis. So this leads us to the combination of spine and pelvis. I don't want to torture you with all these angles, but just to get an idea. The most important one are the lumbalordosis and the sacral slope. I'm going to show you in a second. And the pelvic tilt. So the pelvic tilt is basically a line, a horizontal line, and then measured from the ASIS to the pubis. And if you have anterior tilt, or you have a good posture, or you have a posterior tilt, and a consecutive flat back, okay, like here. These are the ones at risk for dislocation. And the other thing you have to think about is the sacral slope. So you draw a horizontal line, and then you go from S1. And this is in standing, so here it's about 40 degrees. And this is the sitting position, okay? So the pelvis tilts posterior, and the sacral slope decreases. And then in combination, the anteversion of the cup increases, okay? So this prevents for posterior dislocation. Again, here in the X-ray, patient with total hip arthroplasty, and here the sacral slope, 43 degrees while standing and 6 degrees while sitting. And you see how the anteversion of the cup changes. This prevents for posterior dislocation. And here the opposite, patient with degenerative spine disease, sacral slope doesn't change. And also, the position of the cup doesn't change while sitting. Okay? And these patients are at risk for impingement and dislocation. And the same thing for patients who have a spinal fusion. Okay? No change of the sacral slope, no change of the cup position, risk for dislocation. This is our approach at our department. It might be a little bit academic, but this is how we do it. So we do the clinical examination, alignment between spine and pelvis, and then we perform X-rays from every patient standing and sitting and measure the sacral slope. And this is maybe the best paper you have to read about this topic, awarded with the O. Frank Award. It's done from New York, and it's the hip spine classification. And to simplify it, it's just 4 groups. You look at the spinal alignment. Is it normal, or does the patient have a flat back? And then you look at the sacral slope. Does it change while sitting or in standing? If a normal mobility, it's a 1A. You have a normal alignment, but a stiff spine, it's a 1B. Spinal deformity, but normal mobility 2A. And these are the one at risk. You have a spinal deformity, flat back, and the spine doesn't move. You have no change of the sacral slope, it's 2B. And then this paper provides you with a couple of what you should do in each group. It's basically that you increase the anteversion. But as you know, by hand, this is quite difficult, and this was a study done all with robotics. We don't have a hip robot at our department, so we have a more pragmatic approach to this, that we use in all 2B cases, we use dual mobility, okay? The French knew it for a long time, but now there are good papers out there that it's safe to use them, okay? So this 11,000 cases, almost 8.5 years of follow-up, survival rate 98%, dislocation rate 0.4, okay? So it's safe to use them in these cases, even in young patients. Also, these are data again from the Australian registry. Revision rate is the same. And now to the last topic, we are going to talk about approaches. So may I ask, which approach are you most familiar with? Who's a posterior approach? Okay, so direct lateral approach, anterolateral, okay, modified, okay, and direct anterior. Direct anterior, only one. So we are a direct anterior clinic. I try to convince you, please come and visit us. We will show you, okay? So the direct anterior approach, okay? So you choose the interval between the tensor fasciae lata and the sartorius. This is how we position our patients. So contralateral leg is on a leg holder. It's not prepped and draped. And it's important that you can move, that you can flex the leg, okay? This makes it easier. The flexion of the leg gives an extension to the thigh, and then it's easier to bring in the stem. Other options are the traction table. Only one consultant at our department is using it, but the main majority is doing it this way. These are some pictures, how it looks in the book. So traditionally you try to find ASIS, then 2 centimeters below, 2 centimeters lateral, and then you make the incision as small as you are able to be. Then you prepare it to the fascia. You open it, you have to be careful. This is the lateral femorocutaneous nerve that you don't irritate it. Then you open the fascia, and then you bluntly you search for the interval between the tensor and the sartorius. And the next thing you try to find is the ascending branches of the lateral circumflex artery. I'll show you in a second. This is how it looks in the German book, so it definitely doesn't look like this, okay? So they are more difficult to find. And here's some intraoperative pictures. So this is the approach. Here you have the fascia. You open it. Here you find the interval. So leg is here, head is there. Sorry. Bluntly, you put in the retractors, and here you see the vessels, okay? You can either ligate them or coagulate them, depends how big they are. Then you do the capsulectomy, or you keep the capsule, like Professor Windhager does, and then you do the osteotomy, remove the head, ream for the cup, this is how you know it, put in the cup, and here you see the flexion, so the leg goes down, here again, so this comes down and makes it easier to access the femoral canal. This is always being discussed when you talk about the anterior approach. What do you do in a revision case, or what do you do if you have fracture of the stem? So there are extension methods, okay? The group from Innsbruck and Munich have published on it. There's a really nice papers with good pictures that you should read. Okay, so first thing, you can extend proximally and cut here the tensor fascia lata. This is how they describe it. It's not absolutely necessary. You can also flex the leg and to have less tension on the tensor fascia lata. And then you can approach a huge part of the ilium. What you cannot approach is the posterior column. So in revisions cases where you have to use a buttress augment or something like this, it's better to perform the posterior approach for the complete overview, okay? And for the femoral extension, you can do this lazy S incision or you go down straight. This would be an example where they even would perform an ETO through an anterior approach. So this is vastus lateralis. The tensor is put dorsal, the tensor fasciae lata is put dorsal, and sartorius is up here. And then you additionally do, like here, and subvastus approach, and then you can do an ETO. Okay, so this is also possible. The anterolateral approach, so the majority of you is using it. You choose the interval between tensor fasciae lata and the gluteus medius. It's maybe the most common approach in Europe, so as in our little group here. You can perform it. Do you perform it usually in supine or in lateral position? Lateral? Okay. Okay, so like the Rottinger or OCM. Yeah. Okay. Very good. Yeah, so you know about this. You search for the interval, then you do the capsulotomy and perform the osteotomy of the femoral neck. The direct lateral approach was very popular in Austria. Now it disappeared, luckily, more or less. It was modified by Bauer. Bauer was head of the department in Innsbruck, and Harding, that's in the UK, very popular. So it's also called the transgluteal approach. Why? Because you cut the gluteus medius. And this is the main problem of this approach, that you see patients with a Trendelenburg limp. How does it look? So this is the gluteus, here's the vastus, and then you cut at the anterior third. You do the incision of the gluteal medius and the vastus. This is how it looks intraoperatively. And then you are able to perform the femoral neck cut at the hip. Posterior approach, most popular in UK and in the US. So there you cut through gluteus medius. It's done in lateral position. It's possible with only one assistance. And in our hands, it's very good for big revision cases. Okay, we don't use it routinely for primary arthroplasty. The main problem with this is that the dislocation rate seems to be higher. Okay, there's a question, but maybe you all answered it right in the test you have to do. Okay, this is how it looks. So here's the troch. Then you do the incision to posterior. You cut through gluteus. Here you see the external rotators. You have to identify the piriformis because this is important because of the sciatic nerve. And then you cut through the tendon. You use a suture that you can reinsert it afterwards. This is really important to prevent dislocation. Okay. Then capsulectomy, and then you have the really great overview of the whole acetabulum. And also the stem approach is very easy with this approach. So which approach is the best? You probably know the answer right now. I'll show you some individual studies, some register data, and some meta-analysis. So this is quite clear. This is a study from the US, I think, that the dislocation rate in the anterior approach is significantly lower than in the posterior approach. Okay. This is a study from Germany, from Charité. They did MRIs after anterolateral approach and the direct lateral approach. And what they found in the MRIs is this significantly more severe fatty degeneration of the muscle after the direct lateral approach. Okay, here you can see it compared to here where I don't see it. And also you see a tendinitis of the insertion of the gluteal muscle, medial gluteal muscle. Okay, so these are the downsides. They also measured the myoglobin directly after surgery, 6 hours and 24 hours. It was significantly higher after the direct lateral approach. This is another study from Germany. They looked at the pain, anterior approach versus the conventional approaches or the lateral approach, and the pain was significantly higher after the lateral approach within the first 24 hours. This is a huge study from the UK, almost 25,000 elective cases. And here you see the mortality rate after each approach. And it was worse in the lateral approach and best in the posterior and in the DAA, in the direct anterior approach. And they concluded that the lateral approach is associated with worse outcomes, including more deaths and revisions than the posterior approach. And for sure they recommend the posterior approach. And this is always also what you should keep in mind. Everybody has better results with the approach they are using, okay? So if you see a study, always think about that, keep that in mind. You can be successful with every approach. These are now data from the Australian registry, anterior approach, lateral approach, posterior approach, and what they found was a higher revision rate with the anterior approach, interestingly. And then they had a closer look, and it was just that there were more aseptic loosenings in the anterior approach than in the other two approaches. While when looking at dislocation, revision rate was lower in the anterior approach, and also the infection risk was lower in the anterior approach than in the two other approaches. Functional outcome was best in the DAA, 10% more were very satisfied than with the lateral approach. And finally, some data from only randomized controlled studies, and they also favor the DAA over conventional approaches. So this is the pain on day post-op 1, and here this is this kind of forest block. So everything here favors the DAA, everything here favors the conventional approaches. And here's the Harris Hip score after 3 months post-op, and here you still see some better functional outcome after the DAA, while after 1 year, results are more or less the same, okay? So it's really about the early postoperative phase, where the DAA is superior to the other approaches. So to conclude the approaches, as I said before, you can have excellent results with all the approaches. The study situation is not clear. There are regional differences. Which approach is used more, they have the better results with. And for the DAA, you see better early functional results, less postoperative pain, a little bit of a higher revision rate. In the Australian registry, it's because of aseptic loosening, but a lower infection rate and definitely a lower dislocation rate. Okay, thank you very much.